Now we will discuss about Q wave. Characters of normal Q wave. Q wave is usually absent in most of the leads. However, small Q wave may be present in lead 1, 2, AVL, V5 and V6. This is due to septal depolarization. That is septal depolarization. Small Q may be present in lead 3, which disappears with inspiration. Depth of the Q wave is normally less than 2 mm, that is less than 2 small squares, and width is less than 1 small square or less than 1 mm. It is 25% or less in amplitude of the following R wave in the same lead. Now the characters of pathological Q wave. Pathological Q wave is deep, that is more than 2 mm or 2 small squares. Wide is more than 0.04 second or more than 1 mm or 1 small square. Should be present in more than one lead. Associated with loss of height of R wave, and Q wave should be more than 25% of the following R wave of the same lead. Now, causes of pathological Q wave. The causes are myocardial infarction, commonest cause, ventricular hypertrophy, left or right, cardiomyopathy, left bundle branch block, emphysema due to axis changes or cardiac rotation. Q only lead 3 is associated with pulmonary embolism, that is S1Q3T3 pattern. Now we should remember the following points. Q wave in V1, V2 and V3 may be seen in left ventricular hypertrophy and may be mistaken as old myocardial infarction. Abnormal Q wave in lead 3 may be found in pulmonary embolism. Abnormal Q wave in lead 3 and ABF may be found in WPW syndrome, confuses with old inferior myocardial infarction. Now we will discuss about R wave. Characters of normal R wave. It is the first positive or upward deflection due to ventricular depolarization. Duration is less than 0.01 second. R wave usually small, less than 1 mm in V1 and V2, and progressively increases in height in V3 to V6, tall in V5 and V6. That is, R is small in V1 and V2, tall in V5 and V6. Normal height of R wave. In AVL, it is less than 13 mm or 13 small square. In ABF, it is less than 20 mm. In V5 and V6, it is less than 25 mm. If R wave is more than 25 mm, it is always pathological. So we should remember that if R wave is more than 25 mm, it is always pathological. Abnormalities of R wave. R wave may be tall, small or poor progression. Now, causes of tall R wave. That is left ventricular hypertrophy. In V5 or V6, it is more than 25 mm. In AVL, it is more than 13 mm. In ABF, it is more than 20 mm. In V1, tall R may be due to normal variant, right ventricular hypertrophy, true posterior myocardial infarction, WPW syndrome type A, right bundle branch block and dextrocardia. Causes of small R wave looks like low voltage tracings, incorrect ECG calibration, that is standardization, obesity, emphysema, pericardial effusion, hypothyroidism, hypothermia. This is the ECG of a small R wave. Now, R wave progression. The height of R wave gradually increases from V1 to V6. This phenomenon is called R wave progression. Now, poor progression of R wave. Normally, amplitude of R wave is stalled in V5 and V6. In poor R wave progression, amplitude of R wave is progressively reduced in V5 and V6. Causes are anterior or anteroseptal myocardial infarction, left bundle branch block, left ventricular hypertrophy, though R is tall in most cases, dextrocardia, cardiomyopathy, COPD, left-sided pneumothorax, left-sided pleural effusion, marked clockwise rotation, chest electrodes placed incorrectly, deformity of the chest wall, normal variation. Now the S wave. Characters of normal S wave. It is the negative deflection after R wave. One third of R wave. Normally deep in V1 and V2 as impulse is going to the muscles of left ventricle than to the right ventricle. Progressively diminished from V1 to V6. Small S wave may be present in V1 and V6. In V3, R and S waves are almost equal, corresponds with interventricular septum. Now QRS complex. Characters of normal QRS complex. It indicates ventricular depolarization. Depolarization of the left ventricle contributes to main QRS as the left ventricle has 2 to 3 times mass of right ventricle. QRS is predominantly positive in the leads that look at the heart from left side. 1, AVL, V5 and V6. It is negative in the leads that look at the heart from the right side, that is AVR, V1 and V2. In V1, S is greater than R. In V5 and V6, R is tall. QRS appears biphasic, part above and part below the baseline in V3 and V4. Normal duration of QRS is 0.08 to 0.11 second, that is less than 3 small squares, and height is less than 25 millimeter. Now various forms and components of QRS complex. Q wave, initial downward deflection, R wave, initial upward deflection, S wave, downward deflection after R wave, RS complex, small initial R wave followed by large S wave, RS complex, a complex with R and S wave of equal amplitude, RS complex, a large R wave followed by small S wave. A QRS complex, small initial downward deflection followed by a tall R which is followed by a large S. QR complex, large Q followed by a small r. QS complex, complex with complete negative deflection, no separate Q and S. RSR complex, small r then deep S followed by small r. RSR complex, tall r then deep S followed by tall r. RR complex, when deflection is completely positive and notched M pattern. Now abnormalities of QRS complex. QRS may be high voltage, low voltage, wide, change in shape, variable. Causes of high voltage QRS, that is incorrect calibration, thin chest wall, ventricular hypertrophy, that may be right or left or both, WPW syndrome, true posterior myocardial infarction in V1 and V2. Now causes of low voltage QRS, that is less than 5 millimeter in L1, L2 and L3 or less than 10 millimeter in chest leads, that is less than 5 millimeter in limb leads and less than 10 millimeter in chest leads, that is called low voltage QRS. The causes are incorrect calibration, thick chest wall or obesity, hypothyroidism, pericardial effusion, emphysema, chronic constrictive pericarditis, hypothermia. Now causes of wide QRS complex, that is more than 0.12 second or more than 3 small squares. The causes are bundle branch block, that is LBBB or RBBB. Ventricular ectopics, ventricular tachycardia, idioventricular rhythm, ventricular hypertrophy, hyperkalemia, WPW syndrome, pacemakers, looks like slab bundle branch block with spike. Drugs, quinidine, procainamide, phenothiazines, tricyclic antidepressant. Now causes of changes in shape of QRS. Right or left bundle branch block, slurred or M pattern, ventricular tachycardia, ventricular fibrillation, hyperkalemia, WPW syndrome. Causes of variable QRS, multifocal ventricular ectopics, torsades de pointes, ventricular fibrillation.